Good morning and welcome you all for the another edition of Online Anaesthesia Postgraduate Teaching Program and Zoom platform, sponsored by Aquila and hosted by A1 Logics. Today we have two lectures followed by a video session. The first topic is preoperative assessment of cardiac patients for non-cardiac surgeries by Dr.Guru Santhiya. That will be followed by Anesthesia for congenital heart disease by Ranjit Karthikeyan. In the video session, we are having ultrasound guided blocks for chest wall surgeries by Dr. Divesh Arora. I have to thank Divesh sir for accepting our invitation for the second time, because his first video is very big hit, you all know. So the session will be coordinated by Sarve Vinodini. So I invite first speaker Dr. Guru Santhiya to deliver a lecture on preoperative assessment of cardiac patients for non-cardiac surgery. Over to Guru Santhiya.
Thank you, sir. Very warm good morning to one and all. Today I'm going to present on pre-anesthetic evaluation of a cardiac patient for a non-cardiac surgery. So, as we all have known, we have been showing some persistent interest towards a cardiac patient presenting for a non-cardiac surgery. Why is that so? The number of patients, cardiac patients, who are presenting for non-cardiac surgery is on the rise, and these patients are responsible for all-cause mortality about 45%, and the cardiovascular incident is related to it, and they are having an increased incidence of perioperative MI and heart failure. Hence, there has been guidelines from American Heart Association, Canadian Society of Cardiologists, and European Society of Cardiology for perioperative optimization and risk stratification and risk mitigation in such patients. The spectrum of cardiovascular diseases not only include IHD, but also includes hypertension, the patients after presenting to us with the percutaneous coronary intervention, patients with heart failure, valvular abnormalities, patients with cardiomyopathies, and rhythm abnormalities. Before proceeding to any other topic further, we actually have to evaluate the patient first in terms of history. What is the presenting complaints of the patient? And personal history would relate them with the smoker being or alcoholic. Pertaining to cardiac etiology, any history which would suggest towards a cardiac etiology like chest pain at rest or on exertion, pointing towards a myocardial ischemia or angina, or dyspnea on exertion or dyspnea at rest, palpitation, syncope has to be taken clearly in case of a cardiac disease which we are dealing with. In case of an examination pertaining to cardiovascular system, we can look for if the patient has got any murmurs in the heart or a third heart sound, or any examination which can include elevated JVP or pedal edema or pulmonary creps and S3 gallop. And you also have to look for the pulse volume and character to determine any cardiovascular problem which the patient may have got. One persistent importance in these days is being given to effort tolerance. Any patient who may be an ischemic heart disease patient, but if their effort tolerance is more than 4, then they can actually undergo non-cardiac surgery with limited risk than the patient who has got less effort tolerance. So what is the proposed procedure which the patient is undergoing, and what is the risk of the non-cardiac surgery which the patient is undergoing? What are the medications the patient is on? How do you risk stratify them, and how do you mitigate the risk? And one important point to note is whether you proceed with the non-cardiac surgery first or you proceed with the cardiac procedure first. Do you want to evaluate further or do you want to go ahead? This is what we'll be dealing in this presentation. So in case of a patient who has got no history of an ischemic heart disease, prudency must be applied to all these factors which may point out to a underlying ischemic heart disease, like patient being a smoker, hypertensive, who has a hyperlipidemia, an advanced age, who has a history of chest discomfort on and off, dyspnea at rest, an ECG showing a strain pattern or an ischemic change. And in non-IHD, we have to put our front towards the chest discomfort or angina equivalent, which may be dyspnea on exertion and angina. Before proceeding to topic further, we need to delineate about certain important parameters which we are going to see. That is the urgency of surgery. Any surgery which has to be taken within 6 hours when the patient presents, that is a limb-threatening or life-threatening surgery, is defined as an emergency surgery. Any surgery which has to be taken within 6 to 24 hours, as in a case of an acute intestinal obstruction or a hip fracture or so, that becomes an urgent surgery. Any life-threatening or limb-threatening which has to be taken within 24 hours. Then comes the time-sensitive surgery, which takes around, you can wait for 1 to 6 weeks. Most oncological surgeries fall under this category because more than 6 weeks, if they wait, the risk of metastasis may be high. And elective surgeries, you can wait for and decide, maybe a cosmetic surgery or a liposuction or a lipomyexcision, anything which is not complicated can wait for a year or so. That is defined as an elective surgery. And the risk of non-cardiac surgery is also important because this surgery itself is associated with an increased risk of perioperative major adverse cardiac events. Any surgery with less than 1% risk of MACE is defined as a low-risk surgery. Intermediate risk is 1 to 5%, and more than 5% is a high-risk surgery. Any open vascular aortic surgery, liver resection, adrenal resection, pneumonectomy, and Whipple surgery is defined as a high-risk surgery in respect to MACE. And minor gynecological procedures, superficial surgeries are defined as low-risk surgeries in MACE point of view. Coming on to the disease proper, the first one is hypertension. In AHA guidelines 2017, any BP of more than 130/80 is defined as hypertension. May it be primary or secondary hypertension, and the cause has to be exactly known. And the patient may present to us with an end organ damage or remodeling like left ventricular hypertrophy, ischemic heart disease, and chronic kidney disease secondary to hypertension. The patient might previously have got an intracerebral hemorrhage or can be coexisting with the peripheral artery disease. In preoperative evaluation, it is imperative to look for ECG to see for any left ventricular hypertrophy and creatinine to know the end organ damage. In case of medications, you withhold ACE inhibitors and ARBs and continue all other antihypertensive agents in the perioperative period. Coming on to a case scenario, he is a 58-year-old male posted for an elective surgery and he's a hypertensive for 10 years. ECG shows signs of LVH and creatinine is normal, but the BP is somewhere around 190/110. But in this case, will you proceed? International guidelines have suggested that any BP of more than 180/110 is associated with increased cardiovascular risk. But there is no compelling evidence to suggest that if you defer this surgery, it is associated with improved perioperative outcomes. So you decide upon what the surgery patient is posted for, and then decide whether you want to defer the surgery or you want to continue the surgery. In case of an ischemic heart disease, our perioperative goal is to find out is any undiagnosed ischemic heart disease which the patient might have got. If the patient is a known coronary artery disease patient, what is the severity? What is the functional limitation which the patient presents to us? What is the therapy the patient is getting? And what are all the preoperative investigations you would order? Do you need any additional testing to find out if the patient can improve in the perioperative period? And how do you reduce the risk reduction? According to Miller 9th edition, recently there was a question asked in Telegram. You defer any elective non-cardiac surgery for 2 months following a myocardial infarction not requiring a PCI, not done a PCI. So it's 2 months. And in the risk assessment, there are a number of guidelines which have come, risk stratifications which have come, and the time-tested one will be a revised cardiac risk index. And nowadays there is a preponderance towards NSQIP, myocardial infarction, and cardiac risk calculator. And these are the guidelines which are available: AHA guidelines, ESA guidelines, and Canadian Society guidelines. Coming on to Goldman Cardiac Risk Index, it is a 9-point index which is actually retrospectively developed in 1977, involving 1,001 non-cardiac patients. Pertaining to history, it is MI less than 6 months carries 10 points, age more than 70 years carries 5 points, and in the physical examination, S3 gallop carries 11 points, signifying heart failure, and significant aortic stenosis carries 3 points, rhythm other than sinus carries 7 points, more than 5 EPCs per minute carries 7 points, and poor general condition and intraperitoneal or intrathoracic or aortic surgeries carry 3 points, and emergency surgery carries 4 points, and the total is around 53. Any class 1 is 0 to 5 points carries 1% risk, class 2 is 6 to 12 points carries 7% risk, class 3 is 13 to 25 points carries 14% risk, and class 4 is more than 26 carries 78% risk of MACE. Coming on to Lee's revised cardiac index, this consists of 6 components. The components include high-risk surgery, which may be intraperitoneal, intrathoracic, or suprainguinal vascular surgeries, or any history of ischemic heart disease like history of MI or an abnormal ECG, history of chest pain, usage of nitrates, and an ECG having a pathological Q wave. In case of history of congestive cardiac failure, we have to look for prior history of congestive cardiac failure, pulmonary edema, or now the chest is congested with the pulmonary rales, paroxysmal nocturnal dyspnea, or a chest X-ray showing a pulmonary vascular redistribution. And history of cerebral vascular disease, diabetes mellitus requiring insulin, and a preoperative creatinine of more than 2. Each of it is assigned 1 point, and it is a 6-point scale. Any point is 0 carries 0.4 risk of MACE, 1 carries 1% risk of MACE, 2 carries 2.4% risk of MACE, and more than 3 carries 5.4% risk of major adverse cardiac events. And this is one of the time-tested cardiac index, which is developed in 1999, and it is externally reevaluated so many times. And it has very poor discrimination in vascular surgery per se, because the study subjects were not included so, and it is a moderate risk determination index. It is also included in AHA guidelines and CCS guidelines, and it does not rule out all-cause mortality, but it rules out only the cardiac morbidity and mortality. Coming on to ACS QIP surgical risk index, it's a 20-point scale, and MICA is myocardial infarction and cardiac arrest scale. This includes 5-point scale, which includes age, ASA physical status, preoperative function, preoperative creatinine, and the proposed procedure. It is a percentage scale from 0 to 100. 0 is lowest risk and 100 is the highest risk. This is actually based on a very larger set of data than RCRI, and it predicts all-cause mortality and MI within 30 days, and it is not externally validated. Postoperative troponin were not taken into consideration, and so no systematic monitoring events were available. So it actually underestimates the risk than RCRI, and it is also suggested in AHA guidelines. So next is a set of patients who will come to us with a percutaneous coronary intervention. May it be a patient who has undergone a balloon angioplasty, or has a bare metal stent, or a drug-eluting stent. So why are these patients our special concern to assess? Prior they were doing balloon angioplasty. So any vascular intervention leads in an endothelial injury, and the response to it is the endothelial revascularization or re-endothelialization. In balloon angioplasty, this re-endothelialization was not controlled. Even then came the bare metal stent, which had again a tight intact lumen. But in this also, the intimal proliferation, as you can see, the intimal proliferation within the stent is not controlled. Then came the drug-eluting stents, which had antimitotic drugs in place to check this neointimal hyperplasia and to prevent any stent thrombus which would occur. So that is why these stents require a minimal period of dual antiplatelet agents or antiplatelet agents to make them mature, and also to check the neointimal hyperplasia which would occur. So nowadays, more of the patients with coronary interventions are presenting to us for non-cardiac surgery. And these stents are important because any dual antiplatelet stoppage within the proposed period can actually lead to increased risk of stent thrombosis. Hence, these patients are of important to us and in the perioperative consideration, because stopping the antiplatelets may lead to stent thrombus, but continuing the antiplatelets may lead to increased postoperative bleeding. So time interval for coronary intervention and NCS has been developed. Any non-cardiac surgery, time-sensitive surgery can be taken 2 weeks after balloon angioplasty, 30 days after bare metal stents. Now the guidelines recommend after 6 months, if the surgery is non-deferrable, you can go after a drug-eluting stent, and it is possibly limited more than 1 year. And it is better to undergo any elective surgery more than 1 year if it is a drug-eluting stent. In the interim period, the patient should be on the antiplatelet agents as suggested by the cardiologist. So in case of a patient with a coronary stent, may it be a bare metal stent or a drug-eluting stent, the continuation of antiplatelets depend upon the thrombotic risk of the percutaneous coronary intervention and hemorrhagic risk of a non-cardiac surgery. In case of a thrombotic risk, low risk the thrombotic risk for PCI is low if there is more than 4 weeks for balloon angioplasty, more than 6 weeks for 6 months for bare metal stenting, and more than 12 months for drug-eluting stenting. The thrombotic risk of PCI is intermediate if it is 2 to 4 weeks following balloon angioplasty, if it is 1 to 6 months following a bare metal stent, and it is more than 6 months and less than 12 months following a drug-eluting stent. And the thrombotic risk of a percutaneous coronary intervention is very high when you do a non-coronary surgery or stop the antiplatelet agents within 2 weeks after a FOBA, or less than 1 month after a bare metal stent, and less than 6 months with the drug-eluting stent. The hemorrhagic risk of non-cardiac surgery must be considered in the perioperative consideration, wherein hepatic resection, Whipple's, TURP, TURBT, prostatectomy, open thoracic surgeries are all associated with high risk of bleeding. And the low risk may be any urological procedure, arthroscopy, cystoscopy, and vascular surgeries like carotid endarterectomy and EVAR and TVAR or limb amputation, wherein you can secure the bleeding points easily, are considered as low risk for hemorrhagic propensity in the perioperative period. So perioperative continuation of dual antiplatelet agents depends upon thrombotic risk versus hemorrhagic risk. If the thrombotic risk is low, you continue aspirin, whatever may be the hemorrhagic risk. You discontinue clopidogrel. You resume within 24 to 72 hours with the loading dose. If the thrombotic risk, as you can see, is intermediate, again, if it is an elective surgery, you postpone the surgery for more than 1 year. But if it's a non-deferrable surgery, you continue aspirin and withhold P2Y12 inhibitors and resume within 24 to 72 hours following a loading dose. And it happens so for any hemorrhagic risk which can happen. But if the thrombotic risk is very high, but the hemorrhagic risk is low, you try to postpone. If it is non-deferable, you continue aspirin and clopidogrel together and mitigate the bleeding which can happen in the perioperative period. But if the thrombotic risk is high and the hemorrhagic risk is intermediate or high, then you continue aspirin, withhold clopidogrel. You can continue bridging or consider bridging with the short-acting IV antiplatelet agents like terofovin, eftifibatide, or cangrelor. I have only personally used terofovin. I don't think these two are available yet. In case of short-acting IV antiplatelet agents, there is still no large number of data which is available to say if you bridge with IV bridging, the perioperative risk of major adverse cardiac events is less. Still, there is limited data on usage of IV antiplatelet agents, but for the sake of the theory, we just have to know that IV antiplatelet bridging has to be done in a patient who has a high thrombotic risk. So how do you bridge it? For prasugrel, you stop 7 days before. For clopidogrel and ticagrelor, you stop 5 days before. On the third day, you start them on terofovin at an infusion of 0.4 mics per kg per minute. And then you just stop it 4 to 6 hours prior to surgery, because the offset time for terofovin is 4 to 6 hours. Once when the surgery is over, after 4 to 6 hours, you can actually, if the bleeding risk is very less, you can try to resume clopidogrel with a loading dose of 300 to 600 milligrams. And if the bleeding risk is high, you can continue with small like IV antiplatelet agents, or withhold the antiplatelet agent and stop when the bleeding risk is mitigated. You follow them up to discharge and decide whether to continue with dual antiplatelet agents or so. Coming on to next subset, who is a heart failure. So heart failure can be with the preserved ejection fraction. These patients actually have a lower adjusted mortality than the patients who have got a heart failure with reduced ejection fraction. In patients who have heart failure, you delay any elective procedure for at least 1 month. If it's an urgent procedure like an intestinal obstruction or a hip fracture, then you delay the procedure for at least 24 hours if it is feasible. And any elective high cardiac risk surgery, you have to defer it for at least 3 months of a newly diagnosed heart failure patients. In these heart failure patients, the perioperative goal is to find out whether they are compensated or uncompensated. You can very well find this out from the history and the examination, and how is the effort tolerance of the patient. In the examination, you look for pulmonary rales, chest congestion, S3 gallop, elevated JVP, pedal edema, and in the history, you look for anything like shortness of breath, cough, paroxysmal nocturnal dyspnea, and so. In the investigations pertaining to heart failure, this has shown a significant propensity to diagnose the patient on who have got failure, that is NT-proBNP, and echo to rule out any new insult which has occurred. In the perioperative period, it is imperative to continue drugs like hydralazine, nitrates, digoxin, diuretics which the patient may have got, and certain patients may be on anticoagulation or implantable cardiac defibrillator. This has been extensively discussed in the previous lecture, and anticoagulation in the form of warfarin has to be bridged in the perioperative period to heparin and then treated accordingly. Coming on to the next subset of patients with prosthetic valves. In any case of prosthetic valve patient who presents to us in the perioperative period, you see what is the underlying pathology for which the patient has got the valve replacement. You see the type of the valve, whether it's mechanical valve or a biological valve. What is the current status of the valve? What is the functional status of the patient following a valve replacement? What anticoagulation the patient is getting, what vitamin K antagonist like warfarin, what is the targeted INR for the patient which the cardiologist aims for. These patients, particularly, you have to look for hemolytic anemia, which can happen secondary to the valve. You have to look for if the patient is jaundiced and LDH and peripheral smear to rule out hemolysis. And echo, if it is recently available less than 3 months, you can actually go ahead with that echo, and if there is no difference in the functional status of the patient. So what are we more worried about this prosthetic valve is, how is the prosthetic valve function and the valve thrombus. The valve, prosthetic valve thrombus, it itself is a life-threatening situation wherein the prosthetic valve in mitral area has got a propensity to thrombose more than the aortic valve, and the risk is more in the first 3 months to 6 months, and then the risk slowly mitigates on its own in the due course of time. So this is an AHA guideline for continuation or withdrawal or bridging of perioperative anticoagulation in case of a mechanical valve and the bioprosthetic valve. In case of a mechanical valve, the patient usually will be on a warfarin anticoagulation. In case of a mechanical AVR with no other risk factors, if the patient needs aspirin, the patient will be on aspirin also in the perioperative period. The goal is for 2.5 INR. But in the perioperative period, if it's a mechanical AVR with no other risk factors, then no bridging is necessary. You can stop warfarin, bring the INR to subtherapeutic levels, do the surgery with minimal risk of bleeding, and bridge the patient in the postoperative period and start on warfarin. In case of mechanical AVR with other risk factors are the patient additionally has an AF or has a prior thromboembolic manifestation, or the patient has a hypercoagulable state or has a reduced ejection fraction. All these patients and mechanical mitral valve patients, the therapeutic INR goal is around 3. In these patients, perioperatively, you stop warfarin 5 days before. You bridge it either with low molecular weight heparin or heparin, unfractionated heparin. If it's low molecular weight heparin, if it is a prophylactic dose, you stop within 12 hours before surgery. If you're using a therapeutic dose, stop 24 hours before surgery. And if it's an unfractionated heparin, stop 6 hours before surgery and proceed to elective surgeries. Once when in the first 24 hours, the bleeding risk is low, you start them on heparin again and bridge with warfarin in the second day and stop the low molecular weight heparin or heparin in the postoperative period. In case of a bioprosthetic valve, initial 3 to 6 months, the patient will be on warfarin and then bridge to aspirin. So biological valve, the patient will be on aspirin, and in the perioperative period, it is okay to continue aspirin in those patients. So coming on to valvular heart disease, the patients with valvular heart disease usually has been evaluated for in the history itself for all the same. In specific, we have to look for how is the RV or LV responding to the overloading conditions and how is the pulmonary artery systolic blood pressure. So in case of an AS, it becomes very tricky for us to handle between a aortic valve and a non-cardiac surgery. If the patient is symptomatic, you actually try to mitigate and postpone the elective surgery if it is possible. If it is a severe valvular AS and a critical patient, the risk of non-cardiac surgery, if it is low, then the perioperative risk may be low. If the risk of non-cardiac surgery, if it is intermediate or high, then the patient is actually going to have a very increased risk in the perioperative period. So based on the severity of aortic stenosis, if it is an urgent surgery with hemodynamic monitoring and increased perioperative risk, we just have to go ahead because there is no other rule. In case if the patient is going to undergo a high risk non-cardiac surgery, say Whipple's, then you consider a balloon valvuloplasty, which is safer. In case if the patient is asymptomatic and has only undergoes only moderate to low risk surgery, it can be performed with an increased risk of perioperative events of MACE. But if the patient is severely symptomatic, you just have to sit with your cardiologist and team and consider doing a transaortic valve implantation before the non-cardiac surgery, which is going to take place if the surgery is going to be a high-risk surgery and the patient is going to be a severely symptomatic patient. But suppose if the TAVI itself has a high risk than the non-cardiac surgery, then you go with non-cardiac surgery with a strict monitoring. In case of valvular MS, when to proceed with non-cardiac surgery and when to proceed to percutaneous intervention. In case if the valve area is more than 1.5 and the patient even having a significant stenosis is asymptomatic and the pulmonary artery systolic pressures are less than 50 millimeters of mercury, then you can proceed to NCS with NCS is non-cardiac surgery with the increased risk. But if the patient is symptomatic with the severe MS or if the systolic pulmonary artery pressure is more than 50, then you will definitely have to talk with your cardiologist about doing a percutaneous mitral valve commissurotomy before doing a non-cardiac surgery. In case of regurgitant lesions, say it be a mitral regurgitation or aortic regurgitation, if the lesions are not significant, and if the patient is not symptomatic with a severe MR or a severe AR and has a preserved ejection fraction, then these subsets of patient may not pose an additional risk. But if the patient is symptomatic with the severe AR and severe MR and has a reduced ejection fraction of less than 30% or systolic pulmonary artery pressure more than 50 millimeters of mercury, then these patients are at increased cardiac risk for a non-cardiac surgery. You optimize them in the perioperative period for measures to decrease the amount of load which the patient is struggling against. If the criteria for valve replacement fit in, and if the non-cardiac surgery can wait, it is prudent to go for a valve replacement than the non-cardiac surgery. So coming on to rhythm abnormalities, the rhythm abnormalities include AF with fast ventricular rate, and this actually denotes a significant arrhythmias, and lethal arrhythmias or potential ventricular arrhythmias actually signify a significant arrhythmias which can occur in the perioperative period. So in AF with fast ventricular rate, what you aim for is rate control, and the preoperative period look for if the patient is previously on any anticoagulation, bridge it as and when necessary. In case of symptomatic bradycardia and high-grade AV block, these patients will require permanent pacemaker before any elective non-cardiac surgery. In case of bundle branch block, these can be either due to age-related fibrosis in the conduction system itself or signify a underlying pathology. In such cases, if there is RVVB, rule out any do an echo, rule out any pulmonary valve dysfunction or right ventricular systolic dysfunction or any pulmonary disease which is precipitating a right bundle branch block. In case of LVB, rule out any myocardial ischemia which has triggered the left bundle branch block. In case of supraventricular arrhythmias preoperatively, like Wolff-Parkinson's-White syndrome, you have to avoid drugs which will block the conduction across the AV node in the perioperative period and continue whatever antiarrhythmics which the patient is getting and mitigate the arrhythmia accordingly in the perioperative period. In case of ventricular arrhythmia, it can be a benign ventricular premature complex, as which can occur in any older individuals or so. Potentially lethal arrhythmias include non-sustained VT, any VPCs more than 5 per minute or more than 30 per hour. These may actually signify, or multifocal VPCs, these may actually signify a underlying myocardial damage or signify any electrolyte abnormalities like hypokalemia or hypomagnesemia which can be treated. And Lethal arrhythmias include sustained ventricular tachycardias and resolving to normal sinus rhythm. This lethal ventricular tachyarrhythmia will require a placement of implantable cardiac defibrillator before undergoing any non-cardiac intervention, which is elective. So coming on to next subset of patients who will present to us is a cardiomyopathy. Cardiomyopathy may be dilated ischemic cardiomyopathy, which happens secondary to myocardial ischemia, and the related mitral regurgitation can be treated by reducing the load which the patient is getting against. The next thing which can present to us is a hypertrophic obstructive cardiomyopathy, may it be primary or secondary to a hypertension, concentric LVH, then leading on to hypertrophic cardiomyopathy. The thing which we are bothered about is the dynamic left ventricular outflow tract obstruction and the mitral regurgitation, which happens secondary to systolic anterior motion of the mitral valve. You look for specific signs and symptoms like exertional dyspnea and syncope. Some patients may be on implantable cardiac defibrillator because of the sudden syncopal attacks which they've got and sudden cardiac arrest which they have encountered before. And these patients mostly on HOCM will be on negative inotropic agents, and it is imperative to continue that beta blockers in the perioperative period as well. So coming on to whole lot of preoperative investigations which we will do. Any patients who's coming for a non-cardiac surgery, may be an intermediate or high risk surgery, we look for the presence of anemia and for the platelet count. So CBC becomes an absolute necessity in such patients because anemia can trigger a perioperative myocardial insult. And renal function test to look for any cardiorenal syndrome. Liver function test only in pertaining patients where they have got a congestive hepatomegaly or so. Serum electrolytes in patients who are on diuretics, on ACE inhibitors or ARBs, and any arrhythmias which can be potentiated in the perioperative period to look for and to treat hypokalemia if at all it is there. And Canadian guidelines actually suggest to do a preoperative NT-proBNP and BNP for age more than 65 years or any patient who has got a cardiac history prior. They advise them to undergo NT-proBNP in the preoperative period. In case of a heart failure or you doubt any hemodynamic compromise, ABG can be done to rule out any acidosis which is pre-existing. In case of an ECG, if you doubt that the patient may have a LVH in case of a hypertension, all those patients can undergo an ECG. But if the patient has just taken an ECG 3 months back with no change in the functional tolerance or effort tolerance, then you need not subject the patient to another ECG, and you can very well go ahead with the same ECG which the patient has taken 3 months prior. So what are the guidelines for echo? Any dyspnea of unknown origin or any patient who has got priorly done an echo, but now the functional limitation is more than before, then to quantify what has happened, you can actually do a perioperative echo. In history, if anything is suggestive of an obstructive disease like Hawkins or a severe valvular disease or severe LV dysfunction like dyspnea at rest, then you can actually go ahead and do an echo even in the surgery which is emergency or urgent. And in case you want to reassess the LV, the patient has got a severe LV 1 year back and you want to reassess the LV. Now it has been 1 year. The patient is coming for a non-cardiac surgery. Then you can actually go ahead and do an echo. Then ECG for exercise stress testing and stress echo. This can be done if the patient is not able to mobilize. Say the patient has got an OAME, functionally incapacitated patient, but you want the patient is undergoing a high-risk non-cardiac surgery. Then you may subject them towards a stress echo and stress ECG because this will alter the perioperative course. Routine CT angiography, coronary angiography for a patient with IHT is not recommended and it overestimates the risk. Coronary angiography and revascularization depends upon individual patient-based diagnosis and management. If the patient has got significant angina or chest pain at rest, suggestive of myocardial ischemia with ECG changes or troponin, in a time-sensitive surgery, then you can actually go and do a coronary angiography based on the risk stratification. And postoperative troponin is actually recommended in Canadian guidelines for 48 to 72 hours daily serial monitoring. They have suggested that most of the myocardial injury following non-cardiac surgery is actually asymptomatic. So only if then you check a postoperative troponin level, will then it alter the course of the perioperative period in the patient who has undergone a non-cardiac surgery. So any patient who is undergoing a non-cardiac surgery, which is of high risk, it is better to do a post-operative troponin levels. So which are the drugs to continue and which to withhold? Beta blockers, it is always prudent to continue. Diuretics, you can continue unless the surgery is going to involve a significant blood loss or significant fluid shifts. It may be for hypertension or heart failure. Now the recommendation is to stop ACE inhibitors, ARBs for 24 hours before surgery and to restart them as and when the patient becomes hemodynamically stable after 24 hours. Any anticoagulants like warfarin, you bridge them with heparin if at all it is necessary, and then stop heparin 6 hours or 12 hours depending upon the heparin which you are using and mitigate the perioperative bleeding. Coming on to antiplatelets, as we have discussed earlier, there are guidelines to continue aspirin and clopidogrel in case if the surgery is stopped or if the patient is undergoing a closed neurosurgical procedure, then it is actually prudent to stop aspirin also because the fatality risk, bleeding fatality risk is high if the patient is continued on aspirin in such procedures. In such procedures alone, you need to stop aspirin and continue in the perioperative period, post-operative period. Any antiarrhythmic the patient is on, you have to continue. Nitrates, calcium channels, and statins also to be continued to decrease the risk of perioperative major adverse cardiac events. The recommendation is very strongly against starting a beta blockers within 24 hours according to POISE study. Any perioperative starting of aspirin, alpha blockers, or calcium channels blockers for the sake of only mitigating the perioperative risk of the cardiovascular events, it is not at all recommended. And coronary revascularization for stable cardiac disease is not recommended. So I've got 3 case scenarios to end the session with. The first case scenario is a 58-year-old hypertensive who has a known IHT. He has met with an RTA and has a vascular injury, which threatens his lower limb. So the patient already has a ischemic lower limb. So this becomes a emergency surgery. In the history, there is MI less than within 2 months, and he is on medications. The medication history is not known, and his effort tolerance has been 4 meds and has remained the same even in the before the RTA. There is no history suggestive of acute heart failure like chest pain or dyspnea or so. His echo taken 2 months back had good LV and no regional wall of motion abnormality. Even though the patient has got MI in 2 months, this surgery is an emergency surgery which is threatening his lower limb. So you do not do any further investigations because 2 months before echo is normal and the effort tolerance has also been normal. So you actually subject the patient to the surgery depending upon the medications which he is taking. It can be a regional anesthesia or general anesthesia. Case 2, he's a 79-year-old smoker with IHT and COPD, posted for an elective non-cardiac surgery. He has exertional dyspnea and palpitation, which is worse than before, and no investigation of the past year is available. So on examination, he has AF with fast ventricular rate, which I said, by the way, is a significant arrhythmia in the first time noted in the perioperative period or preoperative assessment. AF with fast ventricular rate with a borderline BP. And in such cases, when there is significant arrhythmia, when this elective surgery can wait, you actually postpone and evaluate the cause and then take the patient up for the non-cardiac surgery. Case scenario is a 60-year-old female who is a diabetic on insulin, posted for Whipple surgery. So this surgery is a high-risk surgery and has a history of TIA. So that makes RCRI 0.2. And has a diabetic on insulin. So RCRI is 3 points. So the effort tolerance is more than 4. ECG and echo is within normal limits. So the RCRI is 3. The procedure itself has more than 5% risk of MACE. And it is a 5.4% risk of MACE is the RCRI 3. But the patient is a more than 45-year-old, has a significant history in with the risk of more than 3. So you actually check the preoperative NT-proBNP levels and it is normal. Say, how will you evaluate this patient is, because the patient's effort tolerance is more than 4 and other investigations has been normal, you need not evaluate further. Since it's a time sensitive surgery because of a tumor, you can actually go ahead with the surgery and do the surgery with the increased risk of NACE. In the post-operative period, you have to do a serial troponin levels and find out if the patient is landing up in a myocardial injury following a non-cardiac surgery. Suppose, say if this patient's effort tolerance is not known, the patient has an OA, not able to do exercise, then what we would have done is, we would have subjected this patient to a stress testing. So this is an AHA guideline and this is the Canadian guidelines. This emergency surgery, as first I have said, the patient on case scenario 1, you proceed to the surgery with risk stratification. In case scenario 2, we have seen an example of significant arrhythmia. We have postponed the planned surgery. See, any acute coronary syndrome, any decompensated heart failure, any significant arrhythmia, and severe valvular heart disease. If you are able to postpone the elective case, first postpone, evaluate, and then do a guideline-directed therapy, and then post for the non-cardiac surgery. So here, in the third example, we have seen the risk of perioperative death or MI with an RCRI. In that, the patient had a score of 3. If the patient had less than 1, I would have proceeded to the surgery immediately. But the patient had a score of 3. Then I moved to step 4 to assess the functional capacity. The functional capacity was more than 4. So no need to evaluate further. You can actually subject the patient to non-cardiac surgery with the increased risk. That is all. Suppose if the patient's effort tolerance to me is not known, this patient has an RCRI of 3. If I'm going to do a perioperative stress testing like dobutamine stress echo or dipyrimidamole stress echo, if there is any abnormality which is found, since it's a time-sensitive surgery, we have to discuss among experts to find out what is the best solution for that patient. So this is the AHA guidelines, which is there for algorithm for non-cardiac surgery. And this is the Canadian Society guidelines. In this, the Canadian Society guidelines does not actually believe in doing a perioperative exercise stress testing, and also doesn't and also it considers the perioperative role of preoperative NT-proBNP and BNP. In this, again, if the patient undergoes an emergency surgery, you can actually proceed with risk stratification. If it is urgent, if the surgery is urgent, you can actually do investigations which are pertaining to that particular patient, risk stratify, and then take. But if it's a time-sensitive surgery or elective surgery, you see for the age, RCRI, and significant cardiac disease. If the surgery can be postponed, it can be postponed. And there is also a mention about postoperative troponin monitoring. In this case, if the risk is high, you measure the preoperative NT-proBNP or BNP. If the BNP is less than 92 nanograms per liter or NT-proBNP is less than 300 nanogram per liter, no postoperative troponin monitoring is necessary. You can actually proceed to surgery, and then you can actually see if it is more than 92, if it is more than 300, then you have to daily monitor troponin for 72 hours and obtain an ECG which may suggest a postoperative arrhythmia which has occurred. In summary, in any patient who is coming to you for a non-cardiac surgery, decide the perioperative strategies in a patient-specific manner, as I have cited in the case scenarios. And as I've seen many of our colleagues asking for a cardiologist for a fitness for surgery. This aches my heart. Never ask a cardiologist or a neurologist a fitness for surgery. It is always their risk stratification which is needed for surgery. Before subjecting a patient, any cardiac patient, to a non-cardiac surgery, you always get an informed high-risk consent. Follow the appropriate guidelines for improved perioperative outcome of the patient. And these are the guidelines from which I have taken my topic from. So JAMA article and 2020 AC and AHA guidelines. It has been very nicely covered in Miller 9th edition. So any of us can, if you want, you can actually go through only 9th edition Miller rather than going through all these references. Thank you.
Thank you, Guru Santhiya, for a wonderful presentation, nutshell presentation. Now, Sarvabhinadri Madam, you can carry on the discussion.
Thank you, Dr. Guru Santhiya, for a wonderful presentation regarding the assessment. There are lots of questions. Most of them are regarding the intraoperative management, but I will try to ask a few questions. what is the role of dual antiplatelet therapy in spine surgery? Patients who are posted for spine surgery, if they are on dual antiplatelet, what is your take for that?
Ma'am, it actually depends upon when the patient has got MI. As I said, if it is a non-elective surgery following an MI, it can be postponed up to 2 months. If the patient is posted for spine surgery, then you can stop clopidogrel, continue aspirin in the perioperative period, follow all precautionary measures which we would follow as per a cardiac patient, continue clopidogrel in the postoperative period. Discontinuing aspirin has been advised only for surgeries like TURP and closed cavity surgeries and neurosurgery.
Okay. What is the risk of persistent intraoperative hypertension? And another question of persistent tachycardia. These are all anyway intraoperative.
Intraoperative tachycardia and persistent hypertension both have been associated with increased perioperative MACE. But or preoperative blood pressure of 180 or 110, 190, 110, if you stop the surgery from happening, the risk of there is no compelling evidence to say that you have to defer the surgery based on 190, 110. If it's a non-cardiac surgery and if the blood pressure can be controlled in the perioperative period, you can very well go ahead depending upon the risk of the non-cardiac surgery. Say if it's Whipple's or so and the blood pressure is continuously high for 1 hour, then you can actually think of mitigating the risk with effective hypertension control and then take up. But if it's a hernia surgery or any cystoscopy, you can go ahead with the surgery because the surgery itself carries very low risk of MACE.
Yeah. And there's a patient with cerebral aneurysm posted for repair. His BP has been persistently 160/100. The neurosurgeon insists on not reducing the BP. So
yeah, obviously, because you aim for, in case of an SAH, you aim for a triple H therapy. That is what you do it in the perioperative period to maintain the blood pressure ahead of an aneurysm. So that is how they, you can actually give them on nimodipine if the patient has got any significant vasospasm. But then they would actually demand a BP such high to maintain, actually we would use noradrenaline to maintain BP in the postoperative period in an SAH. That is not wrong.
Okay.
Madam, I want to add some more regarding this question.
Okay, sir.
The maintaining of hypertension in the intraoperative period for aneurysm is mainly to avoid delayed neurological ischemic disease.
Ischemic changes.
That is DNID, they will say. But if you look into the cause for the DNID, it is mainly due to the disturbance of autoregulation and also microvascular thrombi. But in recently published 2019 Anaesthesiology, there is one article. They have extensively done a retrospective cohort analysis and they found that there is no relation between hypertension and hypertension with the delayed neurological ischemic heart disease. But there is a definite correlation between hypocarbia and delayed neurological ischemic heart disease.
Sir, if I may add, we had two such patients, sir, post cerebral aneurysm clipping. We had one patient for whom the BP was 140 and the patient developed neurological deficit. Once when we increased the BP to 180, the patient's neurological deficit vanished in just 5 minutes, sir. Like,
it's a controversial topic.
Yes, sir. It's a waxing and waning, which we have seen in the perioperative period. But
you cannot say this level of blood pressure
BP,
maintain because it varies between the patients.
Sir, rest of the questions, shall I take it on personal chat?
Any other interesting questions you can ask?
The role of subarachnoid block in patients with moderate aortic stenosis.
Moderate aortic stenosis, yeah, some of my senior consultants, I have seen them doing, even that is controversial. Some of my senior consultants, I've seen them doing, start on a phenylephrine or a noradrenaline infusion, and then they would give a low dose spinal anesthesia. It actually depends upon the individual experience and how comfortable are you with that particular procedure.
You can consider in severe, it is contraindicated.
Contraindicated.
Yeah, depends upon the patient and the anesthetist.
Yes.
And okay, rest of the questions I think you can take on. Some questions
I'll take it,
been covered in your talk.
Okay. Okay.
The next lecture is going to be by Dr. Divesh Arora. He's a director and HOD of Anesthesia and OT services in Asian Hospital. He had already been to our forum and he had presented the intescalene block some weeks before. He's an NABH assessor also. He's a green OT assessor and he's a past president of ISA Haryana State Branch. Over to you, sir.
Welcome, Divesh.
Thank you very much for the warm welcome. It has been the second time I'm here, first for interscaling block in the month of January. So I thank Dr. Guru Santhiya, Dr. Edward Johnson, sir, for having me once again. So today I'll be talking about ultrasound guided blocks for chest wall surgeries. So these are going to be some of my learning objectives. First, we'll have an introduction, and anatomy knowledge is, as you know, is very essential for all these blocks. Then specifically, we'll cover paravertebrals, pecs, serratus anterior, and ESP, which is my favorite block. And then we'll do a literature review as well as summarize everything. So, my dear friends, up till 2010, if we actually see regional anesthesia for chest wall surgeries, it was limited to gold standard number 1, that is thoracic epidural, and gold standard number 2, that is thoracic paravertebral block. But over the years, we have realized that epidural technique is no more the gold standard, as published by a famous anesthesiologist of Indian origin, Dr. Narendra Raval, published in RAPM 2012, where he had cited that if you have to cite a epidural, first of all, it will lead to bilateral effects. We have done a right side thoracic surgery and we do not want effects on the left side. Plus, it involves a lot of technical expertise. Not everyone, as a beginner in anesthesia, can do this. Plus, there are risks to the record and adverse effects like hypotension, which we have seen whenever we give a thoracic epidural. But with the better understanding of the anatomy and with availability of ultrasound guidance, since 2011, we have had so many chest wall blocks which have been described for chest wall surgeries. So let's look at the anatomy of the chest wall. We'll start with posterior and come towards anterior region. Posterior chest wall extends from the axillary line, that is the posterior axillary line, to the spinous processes. It is generally supplied by the dorsal rami of the thoracic spinal nerves. Additionally, it also receives branches from the posterior divisions of the lateral cutaneous branches that arise from the intercostal nerves. So coming on to the innervation of the anterolateral chest wall and the axilla, and the famous surgery which we have to understand regional anesthesia technique is the breast surgery. So it is by the branches of the lateral cutaneous branches of the thoracic intercostal nerves, principally T2 to T6 for breast and T2 to T9 for other surgeries. Brachial plexus innervation is also there in the form of medial pectoral nerve, lateral pectoral nerve, long thoracic nerve, which supplies serratus anterior, thoracodorsal nerve, which supplies latissimus dorsi. And if you look at the supply of the axilla, it is by intercostal brachial nerve, branch of T2, and medial cutaneous nerve of the arm, also known as MBCN, which is a branch of brachial plexus. And if we closely observe, certain cervical plexus branches like supraclavicular nerves with medial, intermediate, and lateral also supply the superior portion of the breast. So this is how we can plan analgesia for breast as well as anterolateral and chest wall surgeries. So now coming on to the innervation of the anteromedial chest wall, which is also an important structure. It extends from the midline from sternum till mid-clavicular line. So it is innervated by the anterior cutaneous branches of thoracic intercostal nerves. So the main trunk of the intercostal nerves, after reaching close to the sternum, it divides and gives rise to an anterior cutaneous branch, which has got a medial division as well as a lateral division, so as to take care of the sternal nerve supply as well as supply from sternum till mid-clavicular line. This fact we have to consider when we are planning analgesia for breast surgeries on the medial half of the breast. So my dear friends, what all blocks are available as regional anesthetist for thoracic surgeries? So as I said, the gold standard number 1 was thoracic epidural with its pitfalls. The second gold standard was thoracic paravertebral block. But with the advent of various interfacial plane blocks, we have so many interfacial plane blocks which have been described, particularly for posterior chest wall, ESP, retrolaminar, and midpoint of transverse process to pleura. These are actually paravertebral by proxy. These will also work for anterior chest wall surgeries, although I've classified them as paraspinal, but actually they block the ventral ramus, that means the intercostal nerve, and they can be effective for anterior chest wall surgeries also. Then exclusively for posterolateral chest wall blocks is the rhomboid intercostal plane block or rhomboid intercostal subserratus plane block. And anterolateral, everybody is aware, pecs and serratus anterior. Anteromedial, as you may be aware or you may not be aware, there are two typical blocks, which are pecto-intercostal facial block and transverse thoracic plane block. So I'll be discussing each and every block in detail. So coming on to the second gold standard, as I call it for thoracic surgery, is the thoracic paravertebral block. Let's understand the anatomy. Thoracic paravertebral space is a wedge-shaped space. It has got a medial boundary, which is the vertebral body. Anterolaterally, we have the pleura, and posteriorly, the structure of interest is the superior costotransverse ligament. Medially, it communicates with the epidural space. Laterally, it communicates with the intercostal space. Superiorly, up till cervical epidural space, paravertebral space, sorry, and inferiorly, it reaches up to psoas major. So how do we actually do this block? There are two approaches which have been described in literature. You can image this space in the transverse imaging or in the longitudinal parasagittal imaging. The main target would be to identify superior costotransverse ligament, and anterior to that is the pleura. And in both imaging techniques, we can do an in-plane as well as out-of-plane approach. So I'll discuss the approaches which are normally used by me and tell you the advantages and disadvantages of various approach. The approach which is normally used by majority of the regional anesthetists is the parasagittal imaging of the thoracic paravertebral space, and we use an in-plane approach. So for us to perform this block, the patient can be either in the lateral position as shown in this figure, or in the sitting or in the prone position. As it is a superficial block, my friends, you can realize that we use a high frequency linear probe. Again, parasagittal probe orientation, in-plane approach, caudal to cranial direction, and 20 ml of the drugs, ropivacaine or bupivacaine half strength is sufficient. And the most important sign which we are looking for is the anterior displacement of the pleura, or pleural drop it is called. So let's look at the small video. The needle is going to come from the caudal to cranial direction. You can see the shimmery pleura. My initial test injection is the intertransverse ligament. So it has not pierced the superior costotransverse ligament. I make small adjustments, and then again I try to pierce the superior costotransverse ligament. Again, I am unsuccessful. Now you'll realize suddenly I have pierced the superior costotransverse ligament visibly, and the pleura goes down. So this pleural line going down means that there is an anterior displacement of the pleura or the pleural drop, and rest of the drug can be easily injected. And once completing the block, you can analyze the other spaces, and then you realize the drug would have reached there also. So another approach which we have been doing in our department is the out-of-plane approach, where instead of coming from caudal to cranial in plane, we come anterior towards the superior costotransverse ligament. We try to pierce it, and we again watch for anterior displacement of pleura or pleural drop, that is called as. Let's have a look at this video. So again, my needle, in this case, out-of-plane approach, the needle cannot be appreciated. It's the indirect movements which happen through the various muscles which can be appreciated. Now you can see the pleura has dropped, and we have completed the block. So coming on to the transverse imaging, a majority of us are doing parasagittal imaging. There are some anesthetists who still prefer to do transverse imaging. And in a review article by a famous anesthesiologist published very recently in 2019, they have cited that transverse imaging should be avoided, because as we are coming from a lateral to medial direction, there is a chances of inadvertent intrathecal or epidural spread is possible, as you can easily see in this skeletal diagram. And we are injecting 20 ml of the drug, which is quite close. So there are chances it can track towards 20 ml. Tracking towards epidural space or intrathecal space can lead to a havoc. So that is why my personal advice is, please practice parasagittal imaging, and try in plane or out of plane, that is up to you. Plus, it is an advanced level block. Start with ESP. Once you are proficient with ESP, then progress towards thoracic paravertebral. So what are the complications and side effects? So I have cited two important articles. First was in 1995 and subsequently in 2017, where they have analyzed the complications of paravertebral block. So the fearful complication is like pleural puncture, which was around 1.1%, and over the years, as performed by experienced anesthesiologists, it has dropped to 0.6%. And pneumothorax frequency is quite less, but these review articles have blocks which are being done by experienced anesthetists. As a beginner, this incidence would be around 5 to 6%. So this is not worth taking a risk. So since we have ESP available, start with ESP and then slowly try to reach towards thoracic paravertebral space. So coming on, starting with the interfacial plane blocks, The first was the PEX, which was described by Rafael Blanco as early as 2011. It's essentially a musculofacial plane block where local anesthetic is deposited between pec major and pec minor, and it targets medial and lateral pectoral nerve. Isolated PEX 1 has got limited indications. So subsequently in 2012, Blanco and his colleagues described PEX2 block, which is essentially a combination of two blocks, PEX1 and PEX2. PEX2 targets the pec interfacial space between pec minor and serratus anterior at the level of third and the fourth rib. And it targets the lateral cutaneous branches of intercostal nerves, long thoracic and thoracodorsal nerve. So let's understand the PEX block technique. It's quite a superficial block. The patient has to be supine, head has to be turned to the opposite side, and arm has to be minimally abducted. Superficial block, so we make use of a high frequency linear probe. Initially, we place the transducer as we would have done it for an infraclavicular block, and then try to move our transducer in the deltopectoral groove with slight medial tilt so as to identify the ribs. The aim is to identify the pec major, minor, axillary artery and vein, and start moving towards axilla over third and fourth ribs. So coming on to the sonoanatomy, this is the third and the fourth rib. The needle is going to come from superomedial to inframedial direction. Initially, we do the PEX2 block between pec minor and the serratus anterior. We inject 20 ml of the drug, that is 0.375% of ropivacaine or 0.25% of bupivacaine. Then we withdraw the needle and come back again to deposit between pec major and minor, thereby blocking the medial pectoral and the lateral pectoral nerves. Here, the volume used is 10 ml of 0.375% ropivacaine. So this is how we do the block. Now I'll actually trace you with the sonoanatomy in a patient. So initial placement is like a infraclavicular block. Then we start moving the probe in the deltopectoral groove and with a medial tilt. The first rib which comes underneath the axillary artery is the second rib. Subsequently, we come close to the third and the fourth rib. Once we sight the third rib, you will realize another muscle comes into picture. That is the serratus anterior. So this is the site, good site to give PEX2 as well as PEX1 block. So let's have a quick look at the video of this block. This is supromedial. This is inframedial. The needle is going to come from this place. So pec major, minor, serratus anterior. The first injection is between pec minor and the serratus anterior, where we actually deposit 20 ml. And while withdrawing, you can complete the block between pec major and minor. That would be the PEC1 block. So is this block actually effective? There have been a couple of RCTs as well as meta-analysis. I am showing just one of them to save on the time. This was published in Anaesthesiology 2019, where they compared PEX block in breast cancer surgery. In compared to control, it was very effective. But in compared to paravertebral block, they stated it is non-inferior. That means it has got good efficacy. So it's a good block to be considered in breast surgeries. So coming on to another block, which was described by Rafael Blanco and colleagues in 2013, that is a serratus anterior plane block. It is a musculofacial plane block again, and it targets almost the similar nerves which were targeted by the PEX2 block. And both superficial as well as deep serratus anterior plane blocks have been described in literature. So how do we actually do it? So for this block to be done, this can be done in supine as well as lateral position. In this pic, I have shown you in a supine position. The patient is placed in a supine position with the arm abducted 90 degrees. So it's a superficial block, so we need a high frequency linear transducer, and it is placed between anterior axillary line and the posterior axillary line. The aim is to identify latissimus dorsi, and we use a Pejunk needle, 8 centimeter, in plane approach, anterior to posterior, and it's a plane block. So we inject around 30 ml of the ropivacaine, 0.375%. So this is the sonoanatomy of the serratus anterior plane block. So needle is going to come from anterior to posterior direction. In this plane, we can identify thoracodorsal artery. So we have to avoid it. We can do either a superficial block or a deep block. Superficial means injecting between latissimus dorsi and serratus anterior. Deep means injecting between serratus anterior and the rib. So here's a small video this side is right side of the screen is anterior, left side of the screen is posterior, and our needle will be coming from anterior side towards posterior side. You can see the pulsatile thoracodorsal artery, which I am trying to avoid. This is a plain block, my dear friends. So you have to deposit around 30 ml and keep moving the needle in the lens of the local anesthetic so created so as to completely distend this space. In case you have any doubt, you can do a deep block also. So which block should we prefer, superficial or deep? Initially, when Rafael Blanco described, he said superficial gives you a wide coverage, whereas deep block gives you a less coverage. But over the years, RCTs have been designed, which have found that there is no difference between superficial and deep. So you can continue doing either of them depending on your expertise. So is it effective? Yes, my dear friends. If we actually compare with control groups, it's effective for breast and thoracic surgery. And on the basis of 5 trials which were included in this meta-analysis, it was not appreciably different from paravertebral block. So both these blocks compared to our second gold standard, that is the paravertebral block. So coming on to my favorite blocks, and this is the most well-described block and most common one these days, I would say, and it is the flavor block for all the regional anesthetists. It was first described by Forero in 2016 for thoracic areas, and now it is available for cervical, lumbar, as well as sacral areas also. So it's essentially a musculofacial plane block where LA is deposited deep to erectospinal plane muscle, and it targets the ipsilateral spinal nerves. So there has been a lot of confusion regarding the mechanism of action. Initial cadaveric studies suggested it blocks only ventral rami very selectively, and blocks dorsal rami in almost each and every case. So our mind raises a question that if it's not able to block ventral rami, how is it effective for breast surgeries? And in my personal experience, I've been using this block since 2017 for breast surgeries, and it is very effective. Even for our previous head of the department of anesthesia, she had cancer surgery. We gave it to her and she was pain-free for next 24 hours. So various studies have been devised, MRI studies and clinical studies, where they have actually found that it is effective for ventral rami block. So let's understand the mechanism of action. See, once we inject our local anesthetic underneath erectospinal muscle, it diffuses in the craniocaudal direction, which we all know. But it certainly gains entry towards the paravertebral space. Some local anesthetic also diffuses towards the epidural space, and also there is a lateral space. So the mechanism which have been explained in recently by MRI studies in Canadian Journal of Anesthesia 2020, they have found that the pleura exerts a negative pressure once the patient wakes up. So certainly the drug gets pulled towards the paravertebral space, thereby blocking the ventral rami. And plus, what happens once the patient wakes up, there is active erectospinal muscle contractions which are happening. So these also tend to push the local anesthetic towards the paravertebral space. So in my clinical practice from the very beginning, we have been using this block towards the end of the surgery. That is why we're getting very good effects, because the patient wakes up immediately, then we get a negative pleural pressure, and then we get a positive contractions of the erectospinal muscle. So how do we actually do it? It's almost similar to paravertebral block, the positioning of the patient. You can do in either lateral, sitting on the prone position. Superficial block, so high frequency linear transducer is good enough. Parasagittal orientation, in plane approach, caudal to cranial direction. Again, we inject the same volumes of the drug, around 20 ml of ropivacaine, 0.375%. So this is how the sonoanatomy would look like once you are actually at the transverse process. Transverse process has got a squared appearance. And if you turn the probe slightly outwards, then you get to see the superior costotransverse ligament. So the needle will come from caudal to cranial direction, inject up over the surface of transverse process, thereby lifting the erectospinal plane muscle. So I'll first of all tell you how to count the ribs. Traditionally, if we use the palpatory method, you'll realize that the thoracic spine overlies on the next spinous process. So for example, if we actually look at this, if I palpate this spinous process, this will correspond to the transverse process of the lower thoracic vertebra. So this fact has to be kept in mind whenever you use a palpatory method. So in order to circumvent this problem, USG can be used to count the ribs as well. So this has been a recently published article in RAPM in 2021, where they have actually showed how to count the ribs using ultrasonographically. So we can use a linear probe, place the probe close to the nape of the neck. So the first vertebra which comes into picture is our first rib. Sorry, the first rib which the first bony shadow which comes into the picture is the first rib. How do we confirm that it is the first rib? You can then move the probe a little laterally and then it will disappear, because first rib is very short and it articulates uh, anteriorly. So let me show you how do we actually do it. So the first rib comes into picture. Okay. Subsequently, as we move downward, you will be seeing the next rib, which is the second rib. Then as we move further down, we get to see the third rib. And this is how we can start counting our ribs and then trace our probe towards the medial direction to count the respective transverse processes. So I'll show you the sonoanatomy of the erector spinae block, how actually we do it. So we do not start from the midline. We actually start 5 to centimeters lateral to the midline. First identify ribs. Ribs have a round contour, and then start to move the probe medially, and till the time we get a transverse squared off contour of the transverse processes, that is the place where we actually start our block. So ribs are round, pleura is well seen. I keep moving my probe towards the medial spinous process. As I keep moving my probe, you will realize another muscle comes into picture. This is the erector spinae plane muscle. And then suddenly the contour will change to a transverse contour. So this is a transverse contour which we are actually looking for. Another important thing is, if you are in a strict perpendicular plane, you will not see the pleura. And if you turn your probe 5 degrees outwards, then you will get to see the pleura. Now I'll be turning my probe 5 degrees outwards, and you get to see the pleura as well as superior costotransverse ligament. Let's look at a video. So right hand of the screen is a caudal. Left hand of the screen is cranial. So my needle is going to come from caudal to cranial in plane approach. And the aim is to hit the transverse process, do a test injection. Once we see ESP getting lifted off the transverse process, then the remainder of the injection can be done. And we can observe the spread of the drug in 2 to 3 spaces cranial as well as 2 to 3 spaces caudal. So the next question which comes to our mind is, as anesthetists, where exactly to inject? On the top surface, on the edge, or in between two transverse processes? So there have been a couple of letter to editors, and it has been my personal observation that if we are injecting closer to the edge or in between two transverse processes, then the drug has a much brighter chance of reaching the paravertebral space. So that is why my recommendation is to inject at the edge or in between two transverse processes. So another approach which has been described in literature is the transverse approach to the erector spinae plane block. So whosoever has attempted this block would have realized that at some times we have given intramuscular injections, which causes these kinds of laminations. So in order to circumvent this problem, there have been 3 papers in the literature which have actually described the benefit of a transverse approach, where this kind of a side effect can be recognized much earlier, and then you can place the needle into a deeper plane. So one can definitely give it a try, and in case you are facing problem with the parasitical orientation. My friends, the next question comes to mind: is it effective clinically? It is effective. There have been so many RCTs. I'm quoting one of the meta-analysis where it was effective, and it was almost comparable to the thoracic paravertebral block. This is another one which has been published very recently in Pain Physician 2021, and they concluded that in this erector spinae plane block is superior to systemic analgesics as well as an alternative to paravertebral block. So now we have coming to the regional anesthesia techniques which can be used for enteromedial chest wall. The target in this case is the anterior cutaneous branch of the intercostal block. It can be between two muscles like pec major and the internal intercostal, or subsequently in a deeper plane, that is the internal intercostal and transverse thoracic muscle. So two blocks have been described. One is the PIFP block, that is the pectointercostal facial plane block. In 2014, it's essentially a USG guided musculofacial plane block, which targets the anterior cutaneous branches, and the LA is deposited to pec major, as I've shown you in the figure. So this is how we can do this block. Patient is supine, a high frequency linear probe has to be placed 3 centimeters lateral to the sternum, in plane approach, caudal to cranial, and we deposit 15 mL of ropivacaine 0.375%. So this is a small video. This is pec major, intercostals. The needle is coming from caudal to cranial direction, and we aim to separate the plane between pec major and the intercostals. So it is also a basic level block which can be done, and it should be done for a breast surgeries, particularly involving the medial half of the breast. So coming on to a deeper block, which is the transversus thoracis muscle plane block. It was described by Ushima and colleagues in 2015. Here the LA is deposited one layer deeper, but it is a dangerous block to me, because in this plane runs the internal memory artery, and transversus thoracis muscle, as I'll show you in this figure, is almost hypoechoic. And the artery running in this plane can, in majority of the cases, cannot be identified as beginners. So I would request you not to attempt this block till the time you are an expert in this field of regional anesthesia. And the previous one, the PIFP, can solve the same purpose. Why not do that? So if you attempt, please realize that there is an internal memory artery which is sitting very close to it. So you have to be careful. So my dear friends, are you confused listening to my presentation? I presented you so many blocks, but now I'll solve each and every confusion. I'll do a good review of literature and tell you which block is to be done in which chest wall surgery. So when we actually talk about chest wall surgeries, there are 4 major surgeries which we are looking for as anesthetists: thoracotomies, VATS, breast surgeries, and rib fractures. So the choice of block will depend exactly the expertise of the anesthetist, where exactly is the surgical incision, and facilities for acute pain services are available or not. So let's come on to the thoracotomy. As whosoever has given anesthesia for thoracotomies would realize these are one of the most painful incisions, and we get pain because of nociceptive somatic pain. We also get pain because of stretching and injury to viscera, and there is certainly a component of referred pain to ipsilateral shoulder, as well as there is a component of neuropathic pain. So Prospect Group, which is a very prestigious group working since almost 20 years, where they formulate guidelines for post-operative pain management. You can go to their website. They are easily downloadable. So in 2015, it has been almost 7 years, and they are due for review for thoracotomies. They stated that paravertebral block should be preferred as the first choice in comparison to thoracic epidural analgesia, because due to lower complication rates. And remember, thoracic epidural will always give you a bilateral effect. And in case you cannot use a paravertebral, then you can think of thoracic epidural. And third is my recommendation that in case you are not that expert citing a paravertebral or a epidural analgesia, please use ESP, and a catheter can be easily inserted. We have done it number of times, and infusions can be used at 4 to 6 ml per hour. What about breast surgeries? We do a lot of breast surgeries, and the Prospect Group came out with guidelines in 2020, where they stated that paravertebral as the first option. Second option, they stated pectoral nerves. But you have to remember that pecs 2 and serratus anterior will not cover the medial half of the breast. So these are my recommendations. Please use PIFP whenever you're using pecs 2 or SAP. And my personal favorite is ESP. So how do I decide whether I have to use pecs or SAP or ESP? It's very simple. If the BMI is around 30 and all, and the patient can be turned to its lateral side, I generally prefer ESP. If the BMI is on the higher side, then my personal preference is SAP with PIFP, and I do prior to the incision, whereas ESP in our department, we do after the surgery is over. So what about VATS? These days, it's an era of minimally invasive surgeries, and VATS is a quite popular surgery. So Prospect Group came up with guidelines in 2021. They are very recent, and they recommend thoracic paravertebral or erector spinae as the first choice. So ESP, although 5 years old, is gaining momentum and is definitely featuring out in our guidelines. And serratus anterior plane block was the second choice. So my personal preference for BATS is ESP. What about rib fractures? As anesthetists, we are called by our intensive care friends to give some kind of analgesia to their patients for rib fractures. So, how do we take a decision? This is a beautiful article which I'll request everyone to go through, published very recently in BJA. So, what should be our plan for rib fractures? If the fractures are situated anteriorly or in the lateral chest wall, but the patient is obese, is not able to sit, roll, and will not give a good position for paravertebral, then we go for serratus anterior plane block. And if the patient has a posterior or lateral fractures, unilateral, but is able to sit or roll to one side, then you have choices like you can go for erector spinae, serratus anterior, paravertebral. And if you have bilateral fractures, then the choice obviously is thoracic epidural at first instance, or a bilateral paravertebral, or a bilateral erector spinae, or a bilateral serratus anterior plane block. So what are the risk and the complications of thoracic wall blocks? So they generally in these planes, we have some vessels running. So there is definitely a risk of puncture to the vessels, hematoma. And for PEX2 serratus anterior, there is a risk of pneumothorax as a beginner if you are not able to visualize your needle well and you are advancing your needle without actual visualization. And obviously, last is a theoretical concern. So generally, it takes 30 minutes for the drug levels to reach their peak plasma concentration. So request everyone to monitor these patients for at least 30 minutes. So there is a lot of confusion regarding nomenclature of the chest wall blocks. So ASRA and ESRA, reputed societies for regional anesthesia, their experts came together and they did some research on basis on the Delphi consensus study. And in 2021 in RAPM, they published the standards which should be used for nomenclature. So in chest wall, SAP is acceptable. For PIFP, they stated that it should be labeled as superficial parasternal intercostal plane block. Makes sense also. For transversus thoracic plane block, they suggested that you should use the word deep parasternal intercostal plane block. PEX1 and PEX2 are out of their recommendation. For PEX1, they stated because you deposit the drug between PEC major and PEC minor, it should be called as interpectoral plane block. And PEX2, because we deposit the drug between PEX minor and serratus anterior, it should be called as pectoserratus plane block. So henceforth, whatever, if you are planning to publish any RCTs, please change your terminology according to this Delphi consensus. So any contraindications? These are usual, that is the patient refusal, allergy, infection at the site of injection. And what about coagulopathy? So if we look at the guidelines by our ASRA, fourth edition, they stated for blocks other than neuraxial, deep peripheral nerve blocks, the management should be governed by consideration of three important things: the vascularity of the space, if actually the vessel punctures, whether you will be able to compress it or not, and if you're not able to compress it, what are the consequences of the bleeding. So they didn't mention which side of blocks, but they made a general comment. But very recently, 1 month back, the European Society for Anesthesia and Intensive Critical Care, as well as Regional Anesthesia Society, came up with some guidelines where they clearly stated which blocks can be done on anticoagulants, which cannot be done. So deep blocks should be avoided. So in context of thoracic wall, you have to avoid epidurals as well as paravertebral, but you can certainly use parasternal blocks, serratus anterior, erector spinae, intercostal, as well as PEX block. But as a word of caution, I'll introduce the deep parasternal intercostal plane block or the transversus thoracic plane block. It's very close to internal mammary artery, although they're recommended, but these recommendations are for experienced anesthesiologists. As a beginner, do not attempt in an anticoagulated patient. So now I have almost covered majority of the blocks, their review of literature, the recommendations. I'll share what is my contribution towards thoracic wall blocks. In response to Blanco's article in 2013 regarding serratus anterior plane block, we wrote a letter to editor in the anesthesia journal in which he had published that serratus anterior will not cover the medial portion of the breast. So I said that you have to deposit the drug between PEC major and intercostal, and I called this block as PEC major plane block. And you will recollect from my previous slides that subsequently in 2014, PIFP, which is nothing but what I had described in literature, was described by Torr and colleagues. Our second contribution towards erector spinae is all those who have attempted erector spinae plane block using an in-plane parasagittal orientation would have realized that it is a steep trajectory block. At times, you may lose the sight of the needle. That is why we described in literature published very recently in 2020, Anesthesia, Pain and Intensive Care, the outer plane approach to erector spinae plane block. So I'll show you a small video. This is the standard of care we normally follow in our department. You can appreciate the needle coming from the anterior towards the posterior surface, and I'm attempting to hit the needle in the transverse process. Once I hit, I give a test injection, and subsequently the main injection is given, and you can very well appreciate the entire ESP getting lifted off the transverse process. So I call this as a beginner's block because this can be very easily done. And if you have residents under you or a fellowship candidates, you can certainly teach them. It's an easy block to perform in the outer plane approach. And once they gain proficiency, then you can ask them to switch over to in-plane approach. So this is an excellent infographic by Dr. Sergi Boada-Pai. He's available on Twitter. You can just subscribe to his Twitter handle, and you will realize he publishes so many of the images. This is one of the image. You can take a screenshot, and once you have time, you can just go through. It is just a summary of whatever blocks are available for chest block, and majority of them I have covered in my lecture. So these are good quality references. You can take a screenshot for them, and these are free in Google. And in case you face any problem, you let me know. I'll be more than happy to share these references. My lecture has been prepared using these high quality references. So it was a complex kind of a topic. So I have tried my level best to resolve all the complexities. Thank you very much for patient listening. And in case you have any questions, I'll be more than happy to answer.
Thank you, Divesh. Very excellent three-pronged approach. That is literature review, video presentation, and pictorial images. Very excellent, sir. Easy to
understand. Thank you very much, sir. Thank you.
Thank you very much to have you again, sir.
It's a pleasure.
It was also wonderful. Wonderful, sir.
Thank you very much. Thank you
so much. I think all the messages are only thanking you. No other questions.
So it makes things easy for me. No more questions.
Thank you, sir. Thank you. It was nice to have you again. Thank you.
Thank you very much. Pleasure is all mine.
With that, we come to the end of this session. So we will meet once again the next week with more interesting topics. Thank you, the today's speakers, Divesh, Ranjit, and Guru Santhiya. Thank you. Thank you so much for your contribution. Thank you, sir.